Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Today, we're diving into a challenging area of rheumatology, the evaluation of pain in patients with chronic inflammatory arthritis. In specific, we'll address spondyloarthritis and its overlap with fibromyalgia. These are two conditions that can blur and complicate each other, making accurate diagnosis and effective treatment a real clinical puzzle. To help us untangle this, I'm joined by Dr. Liron Kaplan, a leading expert who has spent years studying the subtleties of spondyloarthritis. We'll explore why some patients with spondyloarthritis experience persistent pain even when their inflammation is under control, how to differentiate active disease from centralized pain syndromes like fibromyalgia, and why getting this right can be the difference between effective treatments and years of frustration for patients. Dr. Liron Kaplan is a rheumatologist and health services researcher focused on spondyloarthritis. He has helped to write the ACR's Axial Spondyloarthritis Treatment Guidelines and is the former chair of the Spartan Group, the Professional Society to Advance Spondyloarthritis Research and Education in North America. He's an associate professor of medicine at the University of Colorado School of Medicine and co-director of the University of Colorado's Program to Advance Spondyloarthritis Treatment, or CU-PAST. The current episode is a deep dive into the art and science of pain management, and it's one you won't want to miss. Enjoy. Liron, welcome to the show.
Hi, thanks for having me.
So we're super excited to talk a little bit about spondyloarthritis, fibromyalgia, and how they relate to each other. But, for our listeners, can you first define what we mean by spondyloarthritis? What diseases does that entail and encompass?
Right, so spondyloarthritis is a family of disorders that are characterized by high inflammation, and they are pathophysiologically and genetically related, meaning that the patterns of involvement of the joints tend to be similar, not exactly the same in any one patient. Spondyloarthritis comes from the Latin meaning inflammation of the spine or arthritis of the spine, and it's different from the general arthritis that most patients suffer from when they have spine arthritis. That would be more degenerative or musculoskeletal in nature. So spondyloarthritis encompasses a number of conditions. The most common ones include axial spondyloarthritis, which is high inflammation of the spine, and then it also extends to related disorders, including inflammatory bowel disease, psoriasis, and an inflammatory condition of the eye known as uveitis, and skin psoriasis. And so all of those together are the family of disorders that are encompassed by spondyloarthritis.
Got it. And they're linked, often, I think, by like HLA-B27. So there may be some like genetic markers that may predispose patients to these group of conditions. But it's my understanding that not every patient with spondyloarthritis has HLA-B27. Is that right?
That's right. The HLA-B27 is really more associated when the patient has axial involvement, meaning that their spine has an inflammatory component. And that's really what the HLA-B27 gene is correlated with. The HLA-B27 gene is a genetic test that one has to be very careful with because there are many types of genetic tests, but in general, we can parse these into two general categories. One in which the gene itself results in an abnormality on the protein level and causes the disease. So either there's a missing protein, dysfunctional protein, or overactive protein. And that's not the type of genetic test the HLA-B27 represents. The HLA-B27 really is an indication of one's ancestry. And because 90% of folks with axial spondyloarthritis come from this particular group, this ancestral group, it's useful actually in nudging a clinician or a patient towards or away from the diagnosis, but it's not the type of genetic test like a sickle cell test or a cystic fibrosis test in which the actual genetic test is an indicator of the presence of disease or not.
Great. Super important because I often get referred patients with back pain and they have HLA-B27, but they may not necessarily have axial spondyloarthritis because it seems like, many HLA-B27 positive patients are otherwise healthy.
That's right. It varies by one's ethnicity and race. And so we know that, for example, in Caucasians, HLA-B27 is seen in somewhere between 7 and 9% of the population. But those with the disease only make up really 0.5%, maybe 1% of the population. And so even with HLA-B27 positivity in that particular background, you are still something like 18 times more likely to not have disease than to have disease. And so it's important to understand that it's really just indicating whether you come from that ancestral disease in which 90% of the disease is present.
It's super interesting. So we're going to be talking a lot about pain today. And how do these group of diseases, the spondyloarthritis, cause pain in patients?
Actually, taking a step back, there are our modern understanding of pain, we really divide pain up into three categories. One is nociceptive pain, and that is the kind of pain that results from an injury or something that's happening at the tissue level. There's nociplastic pain, which has to do with pain sensitivity or the processing of pain. And then there's neuropathic pain, which is pain that occurs due to dysfunction of the nerves themselves, the ones transmitting the signal between the tissues into the brain or within the brain, interpreting that signal of pain. And so with spondyloarthritis, you can have the presence of all three of these types of pain, but in general, the one that we use immunosuppressants to treat is going to be the nociceptive pain, meaning we're trying to treat inflammation out in the tissue or respond to damage that's out in the tissue in order to modulate that and make patients feel less pain.
And is there a characteristic to the pain that patients with like active spondyloarthritis experience? Do they describe it in certain words or use certain terminology to describe or patterns that is useful for rheumatologists to be able to identify and say, oh, this is probably tissue damage related pain?
Yeah, that's a really good question. The central concept within spondyloarthritis, if it involves the axial spine, is that of inflammatory back pain. And this is a concept that we know is unfortunately alien to many providers outside of rheumatology. But inflammatory back pain means that the pain improves with activity and worsens with rest or sleeping, inactivity, or at least doesn't improve. And that is classically the type of symptom that one might rely on in part when making the decision whether to alter the patient's medications. There are also, so outside of the spine, you can have involvement of ligaments and tendons, a condition known as enthesitis, and that's characteristic of the spondyloarthritis. And where these tendons insert on the bone, that can be the source of inflammation. And that type of pain is indicative of pain with movement of the joint or the muscle that's attached to the bone. And so it's a local type of pain, and the physical exam can help elicit that type of enthesitis.
Got it. Love it. So in the history, sort of that idea of inflammatory back pain, back pain that improves with activity and usually gets worse with rest is important. And then the physical exam, palpating at the entheses, all these sites where tendons attached to bones can help us try to sort things out. But you mentioned before that spondyloarthritis can cause all these three types of pain. Talk a little bit more about sort of the nociplastic pain and how that relates to conditions such as fibromyalgia.
Let me just also make one remark about the inflammatory back pain. It's important to know that in the past, we considered this really the cardinal symptom of axial spondyloarthritis, but with more recent research, we do realize that there are not insignificant number of patients who have inflammatory back pain, but there are a substantial number of patients with axial spondyloarthritis who don't have inflammatory back pain. And similarly, there are folks who have inflammatory back pain who don't have axial spondyloarthritis. So it's not that sensitive and not that specific, and that's been a discovery that's made it more challenging to diagnose these folks.
So then what would be the gold standard for those patients that either do or do not? Is it imaging studies?
Yes, we have recently completed a study that corroborates the findings of prior studies showing that providers weigh very heavily, more so than anything else, imaging studies. And when it involves the axial skeleton, that is the sacroiliac joints within the pelvis or the spine, then the MRI is by far, and other imaging modalities, but in particular MRI is by far the most commonly relied on modality for identifying what's going on,
Got it.
whether the patient is active and whether they have the condition or not.
Yeah. So actually, just last week, I saw a woman. She was in her 50s. She provided a history remarkably of like very classic inflammatory symptoms and, had been managed in the pain clinic with injections and whatnot. And I thought, oh, this could be axial spondyloarthritis. But, then we did imaging with radiographs and they were totally normal, and MRI of the sacroiliac joints and it was totally normal, and inflammatory markers and they were totally normal. So I guess in that case, even though she did have symptoms of inflammatory back pains, she probably does not have axial spondyloarthritis.
Probably not. We know that 95% of folks with axial spondyloarthritis will have changes in the pelvis, in the sacrum, that will allow the provider to, or that are compatible with axial spondyloarthritis. Only 5% of folks are going to have abnormalities that are restricted to the spine. So that's pretty uncommon that you'll have to do anything more than image the sacrum. With that, I would say two things. Number one, that it's critical that you perform the most current sequences when you're ordering the MRI. So it's important to know which MRI to order. And that's really important to stress because when most people have chronic back pain, it's a very different MRI to capture the musculoskeletal problems, the nerve impingement, which explain most lower back pain. 20% of folks within the United States, within North America, are going to have chronic back pain, meaning back pain lasting more than 3 months at some time in their life. But of that 20%, 19 to 19.5% are going to be explained by non-inflammatory causes, things like damaged discs, nerve impingements, poor alignment. And so it's important to know which MRI to order and to order the correct MRI and the correct sequences of the MRI. The second point that I'd say about MRI is that increasingly it's going to be incumbent on rheumatologists to become familiar with how to read these MRIs themselves in the same way that we have to be comfortable reading X-rays. And while rheumatologists may not do as good a job of detecting, tumors and nerve impingements on the MRI, what we really should be comfortable with is reading the MRIs ourselves. And I make it a point within our program at the University of Colorado to train all the fellows that come through on how to be comfortable reading MRIs at the point of care. And I would say, if I can get on the soapbox here, I would say if you're at a program that doesn't do that, there are training modules that you can find on the internet that will train you how to read an MRI for the purpose of detecting axial spondyloarthritis. And you really need to include that in your tool belt before you leave fellowship. So, I would search out those programs or search out workshops on how to read the MRI if you're not being taught it.
Great, Liron. If you could provide us with some of those links, maybe we can put it in the show notes so that listeners can go there and learn how to do it. Because I understand that not every change in the sacroiliac joints also is necessarily consistent with spondyloarthritis. I had a young woman who was a college basketball player, and she had some changes in the SI joints. We struggled trying to define, is that related to a spondyloarthritis or not? Because she's, obviously very physically active.
Yeah, that's an excellent point that you make. There have been a number of studies now, multiple studies that have been performed in different populations to try to get at this issue of how often we see abnormalities in the sacroiliac joints that are unlikely to be attributable to inflammatory disease. And these studies have been done in pro athletes, soccer players, long distance runners, and then folks just in the general population. None of these suffering from any of the symptoms of axial spondyloarthritis. And when they image these folks, up to 20% of them will have some type of abnormality in the sacroiliac joint. So they're actually really common. And those numbers don't differ substantially from really the findings in related conditions such as rheumatoid arthritis, where you also see approximately 20% of folks with changes that might be interpreted as osteitis or inflammation in the bone near the joints. And those are, healthy folks with no signs of rheumatoid arthritis that have 20% abnormalities. And so it's not uncommon that you see these changes even in healthy adults when you just image them.
So, Liron, what you're saying is that it's complicated.
It is. It is complicated, but it's not a challenge that we can't overcome. We know that if folks undergo training, that they can do actually a pretty good job of interpreting these MRIs, and it is the way forward. So
amazing. All right. So going back to where we were headed with this idea about nosoplastic pain and its relationship to spondyloarthritis. Can you talk a little bit more about that?
Yeah, so nosoplastic pain is pain that occurs because of a disorder of pain processing. And the current concept there is that folks have greater sensitivity to pain. So if you think of your pain sensing system as a radio, it's not that the signal is somehow different, but more that the volume essentially is turned up on their pain sensing system so that the typical exposures to painful stimuli elicit a sense of pain at much lower levels. And this nosoplastic pain can occur in folks with spondyloarthritis. We see it based on studies approximately 15% of the time in folks with spondyloarthritis. And that's not so different than the 18 to 24% of folks with rheumatoid arthritis that also experience this nosoplastic pain. And nosoplastic pain is also characteristic of isolated pain disorders, meaning pain disorders that occur on their own or independent of, or maybe in some cases secondary to inflammatory diseases. So one can have what is classically a chronic pain syndrome, such as fibromyalgia, as a standalone syndrome, but also it can occur, as I said, 15% of the time in folks with axial spondyloarthritis.
Yeah. We did a great episode about sort of fibromyalgia and nosoplastic pain with Dr. Howard Schubiner. For those listeners interested, is episode number 39. I think it was a very highly popular downloaded episode that sort of goes into the nitty-gritty details for this. Yeah, so it seems like, as you mentioned, that this diagnosis of fibromyalgia may be more common in patients with rheumatic diseases, including spondyloarthritis, than in the general population. And it may be, that because of sort of the inherent pain that occurs from inflammation may somehow sensitize patients to develop sort of these secondary pain syndromes, secondary to the initial to the inflammatory insult.
Yeah, that's right.
So 20% of patients, so it's a fifth of patients with spondyloarthritis have this. So first, why is it so important to try to distinguish whether somebody's experiencing pain from active spondyloarthritis versus pain sensitization or fibromyalgia? And how can we try to sort that out and distinguish between the two?
Right. Well, it's important to distinguish between the two because in many cases the treatment is so different. And if a person has a nosoplastic source for their pain, then you don't want to use immunosuppressants or change the immunosuppressant and have the sort of waste the opportunity to utilize that immunosuppressant in the future because the patient has very low likelihood of responding to a nosoplastic cause of the pain with a change in immunosuppression. And similarly, if a person has a nociceptive pain that's coming from actual inflammation, then it makes more sense to try to treat the pain at its root cause than to treat the secondary effects of it by using medications that are focused on nosoplastic pain.
Yeah. And so how should clinicians try to sort this out if, you have a patient with axial spondyloarthritis who continues to complain of low back pain? Are there things on the history or physical exam, or do they require other diagnostic studies to try to sort that out?
Right. So absolutely, a clinician needs to rely on the full complement of the tools at their disposal, and that includes the history first and foremost, the quality of the pain. So if the pain is, for example, coming from a discrete repetitive motion and has the characteristics of tenderness right at the insertion of say, a tendon on a bone, then it might represent enthesitis. And so that might require a change or augmentation of the immunosuppression. If there's lots of morning stiffness, typically morning stiffness lasting greater than an hour, improvement with exercise, worsening with rest, all of those are characteristics from the history that might push you more towards an inflammatory nociceptive type pain that requires change in immunosuppression. The physical exam can be utilized with a single maneuver examining, say, a joint, or with multiple maneuvers. And there's some evidence from the literature that using multiple physical exam maneuvers may enhance the reliability. And so that's one tool that the clinician might use to try to distinguish between these two.
Talk a little bit more about that. Help me understand what do you mean by like multiple maneuvers to try to sort this out?
Right. So, for example, if the person has an abnormality in their AC joint, which is one of the joints of the shoulders, one might look at cross-shoulder adduction, and then the Paxinos test, which is a certain way of putting pressure on the posterior AC joint to see whether both of those maneuvers elicit the requisite finding. If one of them do, then you have to be a little bit more skeptical. And if neither of them elicit the finding, then it makes it unlikely that the AC joint is the cause of their shoulder pain. Yeah, so that's an example of how you might use more than one physical exam maneuver on a particular joint to identify the cause.
Got it. So you're saying about the history, the physical exam, palpating each thing, each specific joint. It's funny that when looking at, for instance, the ACR 1990 criteria for the diagnosis or the classification or fibromyalgia had all these tender points, right? And I believe many of those things are around the entheses.
Yeah, and that's a challenge. That's a huge challenge. But the purpose of the classification criteria are to produce a very homogeneous population, folks with the classic presentation of the disease. And we only use those after the diagnosis is made. So first step, if you're trying to enroll someone in a study, for example, and you're looking for classic cases of the disease, the first step would be to make the diagnosis, which emphasizes the sensitivity of your approach, meaning you don't want to miss out on any patients, even if they're not classic manifestations of the disease. And then the second step would be to apply classification criteria. But those classification criteria might be useful in giving you a general idea of what the classic representation of a disease is, whether it's fibromyalgia or axial spondyloarthritis, but they shouldn't be there to replace the clinician's use of their own judgment and their understanding of the particular patient in front of them to make the diagnosis.
Yeah, that makes sense. And so is there a role? So you mentioned the history and physical exam, which is sort of bread and butter for this. Is there a role for imaging or lab tests to try to sort this out between fibromyalgia and spondyloarthritis?
So the difficulty on the fibromyalgia side of the equation is that, at least for population groups of patients, there are some types of imaging modalities that can distinguish that group of patients. And I'm thinking in particular of brain functional MRIs. But those are not at the stage where we use them for individual patient diagnosis. It's not considered a standard of care. And we frankly don't know whether they're reliable enough for an individual patient, even though we see differences. We will look at whole groups of patients. And so the fibromyalgia diagnosis is one that's really heavily reliant on physical exam and history. Whereas axial spondyloarthritis and the spondyloarthritis in general, they rely on lab tests and imaging studies to identify both the diagnosis as well as the level of activity in an individual patient. And so I'm thinking in particular of the C-reactive protein, which is a blood test that is associated with inflammatory conditions, less so the SED rate, which is another one, which doesn't perform quite as well. And those are sort of the standard blood tests that one might use. And then there are more novel, more recent approaches, things such as the neutrophil lymphocyte ratio, which is also a blood test, but based on the relationship of the percentage of different types of cells in the blood. And some work by Rowan Sen at the University of Alabama, Birmingham, indicate that when the neutrophils are higher, above a ratio of 3.7, that might indicate more inflammation. And so that's a more recent development and one that needs corroboration probably in other studies before it's adopted wholesale, but it's on sort of the vanguard of how we think about these conditions. Most importantly, we use MRI and point-of-care ultrasound for identifying disease activity. And so MRI is the imaging modality that shows a much greater sensitivity compared to the traditional X-ray for folks with axial, that is, sacrum and spine involvement in this disease. And that's why I earlier emphasized the use of MRI and the need for rheumatologists to become familiar with that imaging modality. And then point of care ultrasound is useful for identifying enthesitis in folks with peripheral involvement, meaning small joint involvement in the spondyloarthritis. And that also, again, is a very operator-dependent imaging modality that can be useful for identifying inflammation in the areas where the tendons insert on the bone.
Got it. So it sounds like, for the diagnosis, you're saying for the diagnosis of fibromyalgia, it's basically history and physical exam are sort of the cornerstone. And then for the diagnosis of whether or not they have active spondyloarthritis, we use everything, the history, the exam, the labs, as you mentioned, and then, imaging studies. I often find, trainees, think about fibromyalgia sort of as a disease of exclusion, that, well, if it's nothing else, then it's fibromyalgia. But, I tell them not necessarily, because many of our patients have fibromyalgia and spondyloarthritis. So, and fibromyalgia and lupus, or fibromyalgia and rheumatoid arthritis. So you can have both, right?
That's absolutely true. And I don't mean to suggest that a clinician wouldn't use lab testing or imaging, even if they considered that a patient had fibromyalgia, because there might be some competing diagnoses that you would want to exclude. But it's not cost effective or frankly useful in a patient in which they clearly have fibromyalgia to endlessly pursue different imaging modalities or lab tests. So you do need the history and the physical as the starting point to inform your decision making and what sort of imaging and lab testing you do afterwards. So
that makes a lot of sense. For a lot of people, fibromyalgia has a very negative connotation, both for patients. When you tell them that they have fibromyalgia, there's this gut reaction. It's like, oh, you think it's all in my head. And also for providers, they often dismiss patients because, they think, oh, they just have fibromyalgia. I'm wondering how you talk about, these disorders with your patients and how you would recommend that your colleagues and all of us think about fibromyalgia.
Well, it's a bit glib, but I've never heard a provider respond to a patient with a glioblastoma, a brain tumor, by saying it's all in your head. It bothers me to no end, because really that's at its core, the sentiment is one of dismissing the patient's concern. Whether, where the location or the source of the pain is, the discomfort doesn't make it any less legitimate. And so I think it's important, both from the provider and more so from the patient standpoint, to have a degree of humility and respect. And so the goal here is to make the patient feel better regardless of what the source is. And it's just a different treatment, if it's nociceptive or nociplastic pain, but it doesn't make the treatment any less real. It doesn't make the disease any less real, and it doesn't make the seriousness of the disease any less important.
Do you have any idea how fibromyalgia affects the patient experience in people with spondyloarthritis?
Well, it's potentially a source of frustration because instead of focusing on the nociceptive pain and simply modifying the immunosuppression, you have to balance that with the concern that the pain might be coming from a different source. And so it does make it more challenging, and that for some patients can be a source of frustration. But as you point out, these two are not mutually exclusive, and so it's still a question of using both pharmacologic and non-pharmacologic therapies to address the patient's issues.
So talk a little bit more about that. So it sounds like, educating your patient about fibromyalgia, legitimizing that their pain is real, having empathy and understanding that, their sensation is real and it can be, severely limiting, and then distinguishing and, the pain is coming from different sources, so our armamentarium needs to be different. So talk a little bit about sort of non-pharmacological and pharmacological approaches to managing fibromyalgia in patients with spondyloarthritis or any of our other diseases.
Well, we know even if a patient has just axial spondyloarthritis that's not complicated by a chronic pain syndrome such as fibromyalgia, that there are important roles for non-pharmacologic approaches. We know that the studies are just as consistent in their findings that physical therapy in using various modalities is helpful for patients with axial spondyloarthritis. And those findings are just as consistent as, for example, the use of the TNF inhibitors. They may not have the same magnitude of effect, but they are consistently effective. And so physical therapy is important as the initial approach for folks with axial spondyloarthritis. To treat the axial spondyloarthritis, patients typically, if there's no contraindication or reason why they shouldn't use these therapies, they will initially begin with non-steroidal anti-inflammatories because the safety profile of those is such that they are appropriate in first-line therapies. And if they don't respond to those therapies with an adequate a trial typically being a month of a non-steroidal anti-inflammatory, whether or two different anti-inflammatories at maximum dose for a month. If they don't respond to that, then the next step is to use immunosuppression. And depending on the guidelines that you refer to, those therapeutic agents might include TNF inhibitors, interleukin-17 inhibitors, and JAK-STAT inhibitors. So those are our three available classes currently approved for the treatment of axial spondyloarthritis. When the axial spondyloarthritis is complicated by a chronic pain syndrome, then there are numerous pharmacologic approaches, and these include probably first and foremost exercise, addressing abnormalities of sleep and sleep hygiene. Cognitive behavioral therapy has been demonstrated in multiple studies to be of benefit for folks with fibromyalgia. There are mindfulness approaches to deal with stress. All of these together constitute a multimodal approach to address fibromyalgia. And then if necessary, there are both FDA and non-FDA approved therapies for fibromyalgia, and these include SSRIs, which are serotonin and norepinephrine affecting medications, such as duloxetine and numerous other medications from that class. There's also medications that traditionally were used to treat seizure disorders and have now been co-opted for the use of patients with pain syndromes. The FDA-approved one is pregabalin, but there's the older gabapentin also that can be used. And then there are medications from the class known as tricyclics that include amitriptyline and nortriptyline, as well as muscle relaxers. And all of these can be used for the treatment of fibromyalgia.
Got it. So yeah, it sounds like, as you mentioned, for active axial spondyloarthritis, starting with NSAIDs and then going into one of the other therapies that you mentioned, and then for and physical therapy and exercise for spondyloarthritis in general. And then for the fibromyalgia, also physical therapy and exercise needs to be a cornerstone. And then all these other things that you mentioned, CBT and various different kinds of pharmacologic agents. How do you counsel patients to sort of distinguish between these two types of pain so that they're Can you get them to a point where they can say, oh, this is my fibromyalgia pain and this is my spondyloarthritis pain?
Yeah, I think patients are different, and some have an easier time distinguishing the one from the other. I have patients who will come into clinic and say, "Oh, this is clearly my fibromyalgia pain," and then patients who will come in and say, for example, "This is the type of pain that I experienced at the beginning of my disease, and I know that, it has the quality, both in terms of the pattern of which joints are involved, how they make me feel, that presented when I had my axial spondyloarthritis." Another, perhaps slightly more subtle clue that it might be coming from a nociceptive pain and the spondyloarthritis is that with the use of therapies, there's sometimes a tapering effect, meaning that as you become due for the next dosage of the medication, you have a greater amount of the characteristic pain, and that could be a clue that, as to the origin of the pain. So you can counsel them with time so that they have a better appreciation for the qualities of those different types of pains. And then at some stage, it is necessary to repeat the imaging, for example, to see whether the sacroiliac joints, again demonstrating the abnormalities that one might see with axial spondyloarthritis that's active. In some cases, it's quite difficult to determine the origin of the pain, and you may pursue an empiric therapy, meaning you may simply just pick one of the therapies to see whether the patient responds. Obviously, that's less preferable because it potentially could require the abandonment of an existing therapy. And we know from some preliminary studies that folks who, for example, stop certain immunosuppression have a 30% chance of not responding similarly if you reinitiate that therapy. And so it's not a decision that you want to make sort of without due consideration.
Got it. Can you tell us a little bit about the prognosis of patients with spondyloarthritis and fibromyalgia? I know all the studies show we're pretty good at getting people into remission with the spondyloarthritis aspect of it. We have a lot of medications, many of them are effective. Sometimes it takes a little while to figure out which is the best medication for a particular patient, but it's pretty good. But for fibromyalgia, it seems to me it's a lot harder to manage over time.
Well, I think that really depends on your orientation and what specific spondyloarthritis you're talking about. So if a person has multiple organs involved, if they have inflammatory bowel disease and axial spondyloarthritis and peripheral arthritis, that might be a more challenging patient to get into remission. And I think as rheumatologists, we sometimes give ourselves a little bit more credit than we objectively warrant. The ACR, which is the American College of Rheumatology, endpoints that we use for our inflammatory diseases, if you really want to be stringent and you want to look at, say, an ACR 70 in the case of rheumatoid arthritis or an ACES 40, the response rates are not huge. When I look at these charts that come out of our studies, we focus on the distinction between the placebo groups and the treatment groups, and we say, we pat ourselves on the back for identifying a difference. But I pay attention to the white space above those histograms, meaning the folks that didn't achieve that endpoint. And they're almost always greater than 50% of folks that aren't getting what we would regard as a resounding response. And so it's hard to say, we're doing a great job with our therapies when you see all that white space of untreated patients in the diagrams. So even with our therapies, I think what I tell most patients is that they can expect to feel substantially better. We may not get them back to their baseline, but we can usually make them feel better. And I don't see my role as trying to convince patients to take medications. I see it as really letting them know how groups of patients that are most similar to them have responded, at least as a group, not at the individual level, to the therapies, and use that as a way to inform their own decision making. And for the patients who respond to the therapies, I usually don't have to say anything more because they feel better and they, of their own accord, decide to maintain the therapy, because even if it doesn't return them to full health, it makes them feel better enough that they feel like it's worth the risk of taking the medications. And I should say for both of these, we don't have curative approaches. These are the approaches that we have are really management. And they, in most cases, are lifelong therapies, whether you're talking about axial spondyloarthritis or whether you're talking about chronic pain disorders. But there's no doubt that fibromyalgia represents both a diagnostic and therapeutic challenge, and that folks can expect that in most cases, like diabetes or hypertension, this is going to require lifelong therapy. And that over the course of their life, things may get better and their disease may wax and wane, and that the provider and the patient together, if they're attentive to those states, that they'll adjust the therapies. And so I don't think it's helpful to cast it in a purely negative light. I think that there are folks with both of these classes of conditions that have robust responses and those who have less robust responses. But that's just part of life, and one in which working together you hopefully can surmount and improve.
Awesome. So it sounds like you're saying we need more research on these topics and better treatments for spondyloarthritis and, fibromyalgia, and certainly the combination of the two.
Absolutely. And I encourage, particularly at this time in which, for various reasons, research may be under threat, we need to remember that all of the treatments that we benefit from now, everything that we use, are the result of folks in the past volunteering for research, standing up and saying, I hope to make life better for myself, but I certainly want it to be better for my kids and for whoever comes after me. And so that attitude leads to better therapies, and they're, desperately needed for both of these classes of conditions.
Yeah, very well said, Liron. This has been a really wonderful conversation about spondyloarthritis. I've certainly learned a lot, and especially a combination of spondyloarthritis, fibromyalgia, how to sort out what's causing the pain in a particular patient. And you certainly gave me some great ideas about how to move forward with that. But, Liron, thank you so much for your time. Thanks for all the work you've done on behalf of, patients with spondyloarthritis and the various spondyloarthritis groups that you've led over time. And again, I really thank you for your time and for all the research you've done.
I appreciate it, John. It's been nice getting to know you, and it's an honor to have this opportunity.
What a great conversation with Dr. Kaplan. We learned that not all pain is created equal. There's nociplastic, nociceptive, and neuropathic pain. Understanding the difference between them isn't just about making the right diagnosis. It's about finding the right treatment, providing real relief, and helping patients lead better lives. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, remember, keep distinguishing between the various types of pain, and of course, stay healthy.